am the Director of Advocacy for Health HIV and lead for the National Coalition for LGBTQ Health. And having worked within the field of HIV and communicable diseases for over 20 years as your moderator for this session, I hope I can bring to the table perspectives as both a long-term and graying consumer of HIV services, but also a frontline leader in the care as prevention field through years of direct service and policy work. And throughout the session, I'll try and add my own insight as we explore the Aging with HIV Roundtable discussion with our renowned providers and long-term survivors alike. And with that, it's clearly shown that with improved access and better utilization of care and treatment services over the years, people are now aging and living longer with HIV. Yet while the care cascade highlights our shared medical successes, it doesn't really show the entire picture of the true cost of the graying of HIV. In fact, health systems often overlook the underlying problem of HIV's distinctiveness, especially as we age and at a time in our lives when we need the best care coordination available. But in an increasing biomedicalized, constrained context of care delivery, the real question that we have to ask ourselves is, what really does the successful aging with HIV really look like? So in bringing together both long-term providers and people living with and aging with HIV to review and reflect upon the current capacity and future constraints of the HIV and aging services sector, we hope to outline some successes and challenges. So some of the key objectives that we'll review through this session are describe some key findings from the second annual State of HIV Aging with HIV National Survey. We'll also identify and describe from a provider and patient advocacy perspectives some key challenges and needs facing persons living with and aging with HIV. And we'll identify some key considerations impacting the current and long-term HIV and aging with services sectors. And we'll outline some implemental short-term and longer-term policies and some strategies. And it's really good timing that we discuss these issues, especially as this past Saturday marked National HIV/AIDS and Aging Awareness Day. And thanks to Tez Anderson, one of our panelists, for founding the day, we only recently marked HIV Long-Term Survivors Awareness Day on June 5th, which also coincided with the 40th anniversary of the start of the AIDS pandemic in the US. And it's sessions and national conventions and conversations like these that help underscore the community of providers, patients, and advocates alike, what the needs and experiences of people aging, thriving, and sometimes struggling with HIV are, many of whom are here today or among the first and second generation of people diagnosed. And among our panelists are also some of the first providers who accepted the call to fight for patients. So let's kick it off. And first up to present is Dr. John Applebaum. And Dr. Applebaum is an internist, geriatrician, and an HIV expert. He currently holds the Laurie L. Dozier Jr. Medical Education Director and Professor of Internal Medicine at Florida State University College of Medicine, where he also serves as chair of the Department of Clinical Services. He's also the chair of the board of directors of the American Academy of HIV Medicine. He also serves with us on the board here of directors at Health HIV, and he has spoken on or been a member of panels and topics such as health issues in the older LGBT patient populations, HIV and aging, and LGBTQ+ curricula in undergraduate medical education. He served as the co-principal investigator for the HIV and Aging Treatment Consensus Project and was the founding co-medical editor for HIVage.org. Dr. Applebaum earned his MD at the University of Miami School of Medicine and completed his internal medicine residency at the University of Massachusetts Medical Center. And prior to locating to Florida, he held positions at Fenway Community Health, at Brigham and Women's Hospital in Boston, Massachusetts. His interests focus on LGBTQ health disparities and aging with HIV. Also, immediately after John's presentations on the survey's key findings will be Dr. Donna Sweet, who will share some additional personally seen and clinical insights into the survey and her years of practice. Dr. Sweet is a professor of internal medicine at the University of Kansas School of Medicine, Wichita. Dr. Sweet is a delegate of the American Medical Association and a member of the leadership for the American College of Physicians as a master and past president of the Board of Regents. In 2015, Dr. Sweet was awarded an honorary doctorate from Wichita State University in recognition for her 35 years of service to patients, as well as her contributions to healthcare as a clinical educator. She is certified as an HIV specialist by the American Academy of HIV Medicine, of which she is also past board chair. In addition to her long-time participation on the COLA board, a laboratory accreditation 501c entity, she is chair of the National Harbor Path Board, an organization that assists patients in accessing HIV, hepatitis, and cancer treatment medication, as well as some other chronic medications. She's a board member of the National HIVMA Board and a longtime member of the Health HIV Board. She has an HIV program in her clinic with federal Ryan White Parts B, C, and D funds, where she cares for approximately 1,300 patients with HIV. And she's also the principal investigator and director of the Kansas AIDS Education and Training Center, as well as director of Kansas Care Through Housing, which is a HOPWA-funded grant project. Dr. Sweet has traveled extensively, nationally and internationally, educating physicians about HIV care and treatment. Prior to medical school, she completed a master's degree in biology with an emphasis on microbiology, immunology, and worked in a hospital lab as a clinical microbiologist. And golf and travel round out her esteemed career. So with that, John, you have the mic and the floor, and have a great presentation, both of you.
Great. Thanks, Scott. And I want to thank the organizers of this session for inviting me to come again, as I did last year, to talk about the results of the second annual survey on the state of aging with HIV. My conflicts of interest disclosures here. And let's start with the survey. And this is information that many of you already know, that the population of persons living with HIV in the United States is rapidly aging. So in 2020, about 60% of persons living with HIV were over the age of 50. And the projection is that by the end of this decade, 73%, or almost 3/4 of persons living with HIV will be over the age of 50. And this is due to two things. I think the most important is that our treatment modalities are much better, and persons living with HIV are actually living longer as a result of comprehensive health care. But also, unfortunately, patients or people are still continuing to get diagnosed with HIV. And I think the data that was recently released by the CDC is that about 10% of all new HIV diagnoses are in the population over the age of 50. And so what are the domains of factors that influence the health of our PLWH? And it includes all of the ones listed here, and we're going to get into each one of these as we present the data. So a little bit about the survey. The survey had 122 questions, some of them qualitative, some of them quantitative. And the eligible participants were any person with HIV who was aged 50 or older, and any person living with HIV from 15 or more years. And in actuality, there were about 6% of people who had answered the survey who were under the age of 50. There were a total of 479 participants. 420 were living with HIV for 15 or more years, and 59 were living with HIV under 15 years. I think the demographics of the survey are similar to what we saw last year, in that most of them were white gay males. And it would be great if we could get more people of color and more women to answer the survey, but it is what it is. Nearly half of the respondents earned less than $50,000, but 88% had some level of higher education. About half of the participants reported receiving an AIDS diagnosis at some point in their life. And those who were 50 and older were more likely to report a past AIDS diagnosis. And those diagnosed more than 15 years ago were more likely to have been diagnosed with AIDS than those diagnosed less than 15 years ago. The good news is that almost all the respondents were on ART, and most of the 94% had an undetectable viral load, but a good number of participants were concerned about remaining virally suppressed, and a third reported some side effect from the medications that they were taking. As we are really concerned, those of us who care for persons living with HIV who are over the age of 50, there are an increasing number of additional medical problems we call comorbid conditions. And about 60% of all the people who responded to the survey reported at least one comorbidity. And the ones that are listed on the left are the ones that most commonly reported, including elevated cholesterol, high blood pressure, joint pain, arthritis, and neuropathy. On a Likert scale of 1 to 5, the average physical health score that the respondents gave was about a 3.4 out of 5. 81% of the respondents took some medication for one of these chronic conditions, and about 40% reported using some sort of complementary alternative therapies. And that number is actually higher than the general population. The general population is about a third of people use some sort of complementary and alternative therapy. We'll see that the pandemic played a number of roles in the results of this survey. I think one is that there were fewer sexually transmitted infections reported, down to 12% last year from 19% the previous year. And this may be, in fact, related to people isolating and quarantining due to the pandemic. Mental health and substance abuse continue to be really important issues, with about 40% of the respondents diagnosed with a mental health condition, more than a quarter in substance abuse recovery, and a quarter reporting having a history of PTSD. About 60% reported some type of memory loss issues. And regarding substances, on the right, you can see some respondents reported use of alcohol, tobacco, marijuana, and a small number of use of opioids. Care coordination is something that we who care for older patients living with HIV are really concerned about. 94% of the respondents had seen a provider in the last 12 months. 3/4 had seen their provider 3 or more times. Again, remember this data was assembled during the pandemic. And 62% reported that they were receiving both primary care and HIV care from the same person, something that we encourage. I know Dr. Sweet and I both provide both primary care and HIV, and it certainly helps with care coordination if the same provider is providing both services. What are some of the barriers to care? And we've seen this time and time again. Stigma, homophobia, ageism, and racism, unfortunately, are out there and may be barriers to care and may actually result in less care. Some of the other barriers to care included having to wait long time for appointments, the cost of care, both visits to providers as well as medications, feeling that their provider may not be knowledgeable about the issues of the intersectionality of aging with HIV. Seeing a provider that was out of your insurance plan, and then issues around lack of convenient appointment times and even transportation, which may have been less of an issue when we get into the data on telehealth. Around engagement with the healthcare providers outside of routine care, about a third of the respondents reported having to use the emergency room at some point, and about a fifth reported engagement with an urgent care service. Now, telehealth is something that that I know that Dr. Sweet and I both used extensively last year during the early phase of the pandemic. And the respondents also made use of that service, with about 40% reporting using telehealth in lieu of visits. And about 19% were actually forced to reduce the number of HIV provider visits as a result of the pandemic. So again, 7% used telehealth in 2019. And I'm actually thinking back, I don't think I did any telehealth in 2019, whereas up to 80% used telehealth last year. Now, what about payment for medical services? The good news is our respondents reported most all are insured, 97%. 60% have public insurance. Not surprisingly, given that we're looking at an over age 50 population, many of whom were over 65 and have Medicare, and about 42% obtain medications through the AIDS Drug Assistance Program. So 2/3 of the respondents had Medicaid and or Medicare, and the use of ADAP was more common in our participants under the age of 50. And even still, a large majority were, even though a large majority were insured, many reported issues of concern about paying for services. 17% of the respondents didn't seek medical care because they couldn't pay either the full payment or perhaps a co-payment. 16% had difficulty paying for their visit to the provider. 13% reported difficulty paying for medications, and also 13% couldn't find a provider covered by their particular insurance program. Regarding other services or sort of non-medical services, 57% access dental care. I would hope it would be higher, but it was 57%, 45% accessed vision care, and only 39% accessed mental health services. Additional wraparound services that we often think are covered under Ryan White, 23% accessed food assistance services and 15% accessed housing assistance. So medications and pharmacy were issues, I think that some of this has to do with the pandemic. 30%, almost a third, experienced issues getting their medications on time. 40% reported developing resistance to a medication, and this was at any time during their treatment course. And about half reported talking to their pharmacist about their prescription. Now, what type of pharmacy was used? Almost 60% used a retail pharmacy, 28% used the mail order pharmacy, 17% were able to use a pharmacy associated with their clinic, 13% another pharmacy, and a small number, 12%, used a hospital pharmacy. Social support is another concern that older persons living with HIV express. 7% reported they don't have access to any type of social support. almost a third experienced at least 24 hours of isolation in the past week. Again, I'm going to remind you that this data was collected during the pandemic. And then the good news, I think, is that 50% have care support when injured or sick. So they have some support. There were concerns about whether or not their income would last their life, and whether or not they might need some hands-on care for them and some more individual care managing their daily living. About a third sought outside support from their extended family for help. Regarding sex and social support, 41% of the respondents reported having sexual contact in the past year. 73% were under the age of 50. And I remind you that a small number of the people that responded to this survey were under the age of 50. But as the age increased, the amount of sexual contact, or the percent of persons who reported sexual contact, decreased. So what are some of the implications of the survey? Well, I think there's a number of them, and we'll cover them on the next few slides. Not surprisingly, HIV and health can lead to psychological difficulties, mental health issues, and poor quality of life. And there may be need for more coordination of care, referrals to other support services, better engagement by the support services and providers the patients are seeing, and then greater linkage to additional services outside the clinic. So again, care coordination is a great way for providers to work with the community organizations, AIDS service organizations in their local community. What we really haven't talked about, and what's I think is a problem now and will be more of a problem as our PLWH age, is reaching out to those folks who live alone and are more homebound. And so this is, I think, where telehealth has really helped. And it's a way for providers actually to reach out to homebound patients and to get patients in, quote unquote, into the office who can't come in for a visit. Health insurance alone is not sufficient for many of the older persons living with HIV. I think it points out to the need to continue the wraparound services, many of which are provided through the Ryan White Care Act, and that there may be additional services that might be needed, such as transportation. As physicians who care for older patients, we're always concerned about the number of medications patients are on and concerns about drug and drug disease interactions. As our patients are aging and they develop more comorbidities, more medications are added, and we run the risk of these issues. Extended use of medication can show a high rate of resistance, and the need for earlier screening of our older patients living with HIV to diagnose some of the potential comorbidities. Social support, huge issue, and it's something that's reported across all the age groups in the survey, and really points out the need for our older older patients living with HIV to really engage socially, despite the pandemic. Substance use, the rates that I reported are higher than the national average for substance use, but there was a higher number that were actually engaged in recovery, which is a good sign. And there's definitely a need in every community for more substance abuse treatment. and absolutely the need to integrate this into the primary care continuum. Stigma has been an issue we've seen among all ages, but it's interesting that more than a quarter reported some degree of stigma or other discrimination, and they saw this as a barrier to their continued care. So, you know, some of the stigma occurs in the provider's office, unfortunately. While providers can be trained in cultural competency, it's really the frontline staff that absolutely needs to be engaged in this. And so we need to make our offices and clinics much more welcoming, and a much more welcoming environment for all patients living with HIV. And the concept of the medical home, where sort of a one-stop shopping is really expanded. It's the basis of the Ryan White Care Act, and it's now moved into regular primary care. And as our population ages, with the high rates of comorbidities, there really needs to be an increased ability to coordinate care. It's easy to do if it's all done in one place. And to use this medical home as a way to coordinate care, to address all of the medical, psychosocial, mental health, and substance abuse issues. COVID-19 really was a barrier to access over the past year, and I think Dr. Sweet and I can certainly talk about that. I've seen that with my patients, and other barriers were still present, including you know, the cost of care, cost of medication, waiting for appointments, and transportation. I think the one positive that I think all of us providers learned through the COVID-19 pandemic is the value of telehealth. And it really emerged as a new vehicle of engagement, not only in caring for persons living with HIV, but for our patient population in general. And I really truly believe that we will continue to be using telehealth in some form or another as we go on. And I'm going to turn this over to Dr. Sweet.
Thank you, Jonathan. That was a wonderful overview of the survey. And you have to take the slides. So I'm going to grab my slides here. Yeah, you should be able to. And what I'm going to do is just look a little bit deeper at the survey. When I read the survey and looked at the answers and the questions, I was very much surprised at how totally correct it was in terms of what I hear from my patients on a day-by-day basis. For those of you who don't know me, I started taking care of HIV patients before we knew it was HIV in 83, 84. And there is such a huge change over this last 40 years in what we saw. And back in the day, and even into the 90s, before we got good ART, it was all about the virus, and the problems we had were all about the virus. We had opportunistic infections. We didn't have good drugs for the HIV. We had all kinds of metabolic abnormalities from HIV and the drugs. You fast forward now to 2021, the bulk of our patients, 94% are virally suppressed, 99% are taking antiretrovirals, and quite frankly, compared to what we used to have to do, the drug therapy is relatively simple. Almost everyone can start on a single 1 tablet a day combination and do quite well, assuming they're able to take the medicines. And the side effects that are still reported there occasionally, at least in my own practice, are nowhere near of the intensity and duration that we had when we were having handfuls of pills for people trying to control their HIV. So we've moved from worrying significantly about the virus to being able to take care of the virus, but at the expense of our patients as they age, coming up with perhaps even more comorbidities than their counterparts who don't have HIV. 57% have high cholesterol, and there's a medication for that, but that's another medication. 57% have high blood pressure, and they tend to develop blood pressure problems earlier in the lifespan than if they didn't have HIV. But there's another couple of medicines. Joint and back pain is very common in anyone over the age of 65. And I'm seeing an increasing number of my patients get into their 70s and having more and more arthritis. And then neuropathy has been a problem, painful neuropathy for our patients for a long time. So not only do we now have a pill for HIV, and it's just one pill, most of these patients are taking quite a few other medications. And as John pointed out, the barrier because of costs and copays and subspecialists gets to be overwhelming for some of our patients. As you notice, their level of income was quite low in today's society, and consequently, as providers, we have to be cautious about how much we open them up to expenses, no matter how many comorbidities they have. So the barriers to care for most of my patients just center around how many different times they need to see a physician, which is why the medical home is so important. And one-stop shopping is something that I, in my practice, and I know Jonathan does too, attempts to do. We want to do the best for our patients, and certainly there are things we need some specialists for. But it behooves anyone taking care of HIV patients to help them understand that oftentimes we can do in a primary care office many of the things that a subspecialist might do at increased cost versus what we're able to do through our clinics. Wait times, cost of care, cost of medications increasingly, as insurance has higher and higher copays. The more diseases you have, the more comorbidities you have, the more medicines you have, the larger that copay is. And certainly most people can't afford to pay half of their income for copays of medications. The fourth bullet is always something we have to worry about. We're providers who age ourselves, but sometimes don't really think about what it takes to be aging with a particular disease like HIV. And then sometimes you need a provider that's not covered by insurance. And one of the things that I have seen happen as my patients age and turn Medicare age, they lose the person they've had for a long time because that person may not take Medicare. And it's extremely difficult, at least in the Midwest right now, to find a good primary care physician who's willing to take on new people with HIV because they don't feel that they know the HIV disease. Lack of convenient appointment times and transportation, always an issue. Certainly been a higher issue, bigger issue in terms of COVID. One of the things that I have done in Kansas over the last 20, 30 years is do outreach clinics where we actually take our providers and services to Western Kansas, to Southeastern Kansas, to Northwestern Kansas. But that was very much disrupted by the pandemic because of the social distancing needs and the lockdown, essentially. So trying to make sure that those patients in rural America continue to get care is where telehealth became critical and still is critical. And I, like Jonathan, believe we will be using telehealth for a very long time in order to get our patients the best possible care. Now, the payer information is difficult because, and it's another reason for trying to do one-stop shopping with a primary care physician who feels comfortable with the more, what I shall call mundane comorbidities, hypertension, hyperlipidemia, even insulin-dependent diabetes now. Those are things we take care of in a non-HIV infected population. And there's no reason we can't do that for our HIV positive patients, because every time we refer somebody out for a comorbidity, there's going to be more pay, more provider visits, more transportation needs, more medications that need paid for. And certainly if you can do that in your own system, the patient doesn't face as much payee problems as if indeed you sent him to a subspecialist for every comorbidity. And I will simply end by saying that the medical home concept is a hugely important issue, especially as our patients age. Comorbidities are common, and actually we know that comorbidities occur earlier in life in those who are co-infected with HIV. So we have to do more screening early on, but need to know what it is we're screening for. But a medical home to consolidate care coordination and trying to get as much as possible in one place for the patients who need it the most is one of the things that I have built my practice on over the last couple of decades. And I think it's allowed our patients to age as gracefully as they can and get as many services as they need. I was struck by the lack of dental care. Just as Jonathan said, I think it's important that we continue to try and make headways in getting the services that all of our patients need, including dental care, vision care, and mental health care. So I'll close by saying the survey is a wonderful instrument to show us what it is our patients live with every day and continue to accumulate more and more different medical problems as they age, just as patients without HIV accumulate more diagnoses and more medications as they age. So I'm available for questions. I know there's some that Scott's going to ask us, but well done, Health HIV, on a survey that helps us address the needs of our patients. Thank you.
Thanks, John and Donna. I mean, these were really great presentations and a lot of valuable info and insight. And it shows that not only, how COVID has impacted the work as of late, but your dialogue clearly indicates that, while medical providers are really good at addressing the challenges that go along with getting people virally suppressed and separately working to address issues as we age, there's still a far greater need for enhanced care coordination, training, and medical education on that cumulative impact of what having a lifelong virus like HIV actually means to an individual. So I think we have some time for a couple of questions. And if you wouldn't mind, I'd like to ask maybe the first one, and this is a two-part question to each of you. So you both gave a really strong overlay of the survey's findings, from your own personal and clinical perspectives. And these key findings show just how far we've come with modern care services and treatment and prevention. But for so long now, both of you have worked to revolutionize the way that providers care for people living with and aging with HIV. And with that in mind, I guess my first question is, how do you personalize or personify that work in your everyday practices? And the second part is, you talked a lot about a medical home. And so how can we do that better job of collaborating with cross-discipline providers to be on a point as you guys are? So I'll open that up to you both.
Tough question, but I think Jonathan hit on it in terms of the stigmatization, and the people have to be comfortable coming into your clinic. And I think hiring and making sure that you have a staff that's consistent and long-term. I have had some of my employees that work with HIV with me for 20 years or more, so that truly it is a home. And we ran into the issue with the telehealth stuff when we were trying to minimize contact with a lot of people because of the lockdown. Patients wanted to come in. They missed coming in. They felt that it was more isolating. And I think that tells us that we had a pretty good system, have a pretty good system going. But I think making sure that everyone in the organization truly cares about the population, is not discriminating or stigmatizing in any way, but trying to make sure that it is an atmosphere of acceptance and giving. It's something that sometimes hard to do. Your job is a job for some people, but for many people in HIV care, it's much more than a job. Jonathan, I know it's true for you.
Yeah, I mean, I think part of it is treating each patient as a individual person. I mean, I really believe in patient-centered care, and it's something I try to instill in all of the staff that we have. Donna, I envy you having staff that's stayed with you that long. I am from an area where there's a lot of staff turnover. They mean well, but they tend to, not stay as long as your staff has. So it's constantly, retraining staff to practice the way you want your practice to run, which is, each person's an individual. I like to get to know my patients as people. And so that's sort of the way I've always done it. And I'm a bit old fashioned, I think, but that's kind of the way I do it. Scott, the other part of your question was about, coordination and even with medical home, there are still issues around communication between providers. I'm in a relatively small city with 2 major hospitals. And honestly, the communication sometimes between the hospitals or between the hospitals and my clinic is less than satisfactory. So I think we as a health system have a long way to go as far as being able to communicate and sort of act seamlessly in the overall care of our patients.
Right. Coming from the direct service world of work, I too, there was a lot of data interoperability issues across that piece. And I think that there, just like you're saying, there needs to be a lot more focus in on what enhanced care coordination is, and not everybody comes into the system the same way or knows all the same providers. So I really appreciate those comments from both of you. And we do have a few more minutes, and we've got a couple of questions from the audience. And this is a good follow-up question. What advice do you have for new and younger HIV healthcare providers who are taking care of long-term HIV survivors? The reviewer said oftentimes there are generational differences of opinion, including how, things like opioids and substance use and sexual risk behaviors are viewed. So what advice would you have for them?
I think Jonathan hit it on the head when he said, treat every patient as an individual. I know what the guidelines say about colorectal cancer screening, but not everybody wants a colonoscopy. And I think being able to gracefully negotiate with patients about what it is they think is important and needs done, and what you think is important versus what needs done. But trying to forge a relationship where they have a say-so. I think if you ask patients across the whole panorama of people we take care of, feeling like they're a partner and someone that's helping make the decision makes adherence to whatever you decided to do much better.
Yeah, I absolutely agree with you, Donna. And I think, there is an age difference between the way I think we approach our patients and some of the younger providers do. And perhaps I don't know, Donna, maybe I was like them when I was their age, but I think some of it is just experience. And, I have, and I know you have, Donna, have mentored young physicians. And I think sometimes there's a value to that for them to sort of learn the way we deal with our patients. And, as you stated before, the guidelines may say one thing, but, it's really, again, like I said earlier, it's patient-centered care and it's shared decision-making. And you need the patient has a say as to how their care is going to be directed. You can advise, but it's ultimately their decision.
I really, really want to thank John and Donna for both of your wonderful insight. And let's probably now switch up gears and sync up with some of the most well-known and well-versed national community advocates that are living with HIV. So while younger persons with HIV have shown higher rates of service engagement compared with their younger counterparts, their successes of prolonging physical health has seemed to undermine other aspects of successful aging with HIV and their interventions. So In this part of today's session, we'll talk with 3 community leaders about their personal, professional, and shared life experiences and put those comments into suggestions to improve some service delivery. And at the end of all of their remarks, we'll go ahead with a moderated roundtable discussion. So please keep those questions coming in, and we'll try to get to as many as we possibly can. So let's introduce our speakers. And first up will be Tez Anderson. And Tez Anderson is an award-winning HIV long-term survivor activist, writer, and speaker who focuses on survivors and HIV and aging issues. And he's lived with HIV since 1983. And he's the founder of Let's Kick Ass AIDS Survivor Syndrome, which is the first and largest group in the world focused on improving the lives of HIV long-term survivors and older adults aging with HIV. He was named one of our 75 most amazing HIV positive people of 2016 by HIV Plus magazine and Pause magazine's Pause 100 in 2015 as a long-term survivor, making a difference really in this fight against HIV. And he's been profiled in ANU magazine, Positively Aware, Pause, Al Jazeera America, and People. And Tez actually coined the term AIDS survivor syndrome to describe the spectrum of sustained trauma survivorship. And that's a psychological state that results from living through the HIV and AIDS pandemic. And especially vulnerable are those who became HIV positive in the 1980s and 1990s when having HIV was really considered a terminal diagnosis. And he created the HIV Long-Term Survivors Awareness Day back in 2014 to shine a spotlight on those living longest with HIV, whom he had felt been forgotten and invisible as we age with HIV. So Let's Kick Ass is based in San Francisco, and it's got chapters in Oregon, Palm Springs, and Austin. And he serves on ACREA's research on older adults with HIV 2.0 advisory committee and the HIV and Aging Working Group. That group recently convened by the Long-Term Care Coordinating Council group to provide some policy guidance to the mayor's office of San Francisco. And he also works on the CDC's medical monitoring project. He lives in San Francisco with Mark Ruiz, his husband, and their Labradoodle Riley. Second up is going to be Val Wojciechowicz. And Valerie has been in the field for 25 plus years and currently manages the Medical Peer Navigator program at CAN Community Health in Florida. And she's a nationally recognized speaker and facilitator. She strives to erase stigma and help others understand the value of reducing stigmatizing language in HIV. And her experiences as a woman openly living with HIV for 35 years drives her determination to educate others. She's extremely passionate about improving the quality of life and education for the HIV and AIDS community. And as a long-term survivor, continues to advocate for her community. And when she's not traveling, Valerie enjoys gardening and nature and her fabulous dog, Chelsea. And we'll lastly round up with Michelle Lopez. And Michelle Lopez is the healthy aging specialist at GMHC, where she serves HIV positive LGBT clients and communities. Her services include individual mental health and substance use screenings, interventions, and referrals. And she also puts on many educational workshops that are relevant to the health and needs of her clients, especially those aging with HIV. And at times and when needed, especially through COVID, Michelle serves also as a client buddy. She's also served as a private consultant for over 8 years. And this era of Ms. Lopez's life actually allowed her the capacity to implement HIV care and services at a primary care facility under the medical practice of Brooklyn Family Medical Center. There, Michelle integrated HIV testing, medical care, and access to ARVs, as well as facilitated access to HIV PrEP and PEP services. So she's also served as a sexual health educator for HIV plus seniors or those at risk. And the service was provided under a contract with a CREA, a wonderful partner organization that serves the over 50 population. And she is known throughout the US as a tireless advocate, as are all. So that said, let's kick ass with Tez Anderson. Tez, you've got the mic. And when you're done, pass that off to Valerie, who will pass it off to Michelle.
Thank you, Scott. Hi, so I am Tez. All that long introduction is really just a way of saying I'm an old guy with AIDS. One of the things that reason I started Let's Kick Ass back in the day in 2013 was to fill the gap, because HIV long-term survivors weren't on anyone's lips. And we've made a lot of progress in that time. But I think the thing that, for me as a person living with the virus since 1983, is that we don't distinguish between long-term survivors and aging with HIV. Yes, I'm aging with HIV, but I'm aging with it for a very, very long time. And I think that one of the whole focus of this topic today was about quality of life. And that's something I've been focused on for a long time, about asking, how does this and how does anything, how does the medication that I take, the treatment that I receive, how does all of that affect my quality of life? And I think that's one of the missing pillars in the current Ending the Epidemic program. And to my chagrin, even in places that should know better, leave out long-term survivors. Because the first thing I do when I get a new report, I get tons of them now, is I type in long-term survivor, and that doesn't show up with anything. And then I check out survivor, and often that doesn't find anything either. So I think in terms of moving forward, in terms of the quality of life, we think about, I think one of the social determinants of health, the additions might be to add length of infection. Because my needs as a person with HIV for 38 years are very different than somebody who has been positive for 10 years with HIV and the current medications, both psychologically and physically. And I think that I was a bit surprised to see that only 17% of people experienced ageism in the survey. I wonder how the question was framed, because I think we experience ageism every day of our lives. And it's the ways that people say, oh, you don't look 62. I've got a list of things I'm going to read you really quickly, because I've got 3 minutes now, I'm happy to say. One of the ways that we can improve our healthcare is to advocate for universal treatment access. It's the foundation of the U equals U pillar. U equals U means getting our virus undetectable and staying undetectable and having an undetectable outload and being unable to transmit the virus to anyone else. That can only come, and as Lancet has just pointed out, can only come through universal treatment access. I think that the idea of social interaction can be underestimated. Most of us feel like the community that we forged and built have forgotten about us as we've gotten older. And I think that ageism is one of those battles that none of us ever imagined having to deal with. And we live with it every day, the way that people look right through us, the way that providers, this question before was about providers and how they can educate their younger clinicians. It's more than just a history of HIV, it was a history of trauma and trauma-informed care. That's what AIDS survivor syndrome is all about, is kicking the trauma-informed care and having it be a lens in which we viewed the person sitting across from us. Because sometimes, I know for myself, I can come across as angry or grumpy. But a lot of times that person that just sitting across the chair from you can be just somebody who's terrified about aging. I mean, when I was 26 years old, my good AIDS doctor, my well-known AIDS doctor said, you've got less than 2 years to live. Well, now I'm 62 and I'm really happy to be here, but it is not just one pill a day for me. I take a lot of other pills for a lot of other things around aging, cholesterol and heart disease and all these issues. And then the psychological issues, which I don't think get enough shrift. I don't get enough focus because we don't have the funding. So until we can include dental, mental, vision, and hearing in overall healthcare, we will have not made the success we need to have in order to engage this population. And I think really understanding that they're coming to you from a place where we lost all of our community. We lost all of our friends over and over again in many cases. And we expected the entire time to be the next one to die. Our mortality was front and center while all of our friends were dying and we were doing caretaking. But one of the things about it I don't want us to overlook is the resilience. I think that a lot of times we get into comorbidities and all these other issues. We forget the fact that we're resilient. The fact that I'm sitting here at 62 and live with HIV for 38 years means that I'm resilient. And I want us to think about that going forward is how do you look at the things that you have in your life that you're still here? And what do we do with the time we have left? For me, that's doing things like this, giving back and trying to form community. So I see on my clock, I've got less than 27 seconds left to go. So I want to say thank you to everyone. It's a pleasure to be on with Michelle and Val. And so at this point, I'm going to turn it over to Val.
Hi, everyone. My name is Valerie Wojciechowicz. Thanks for the intro, Tez. And thank you to Health HIV, not only for inviting me here, but for doing this work, which has been much needed for a very long time. I work with patients directly, and I work with a team of peer navigators who work directly with patients. And it's so interesting that no matter where we are in the country, we experience the same challenges. You know, folks will say to me at a new clinic or somewhere we're putting peer navigators, they'll say, oh, the stigma is really bad here. And, you know, I thought that my location was the only place that the stigma was really bad. But what we've discovered is the stigma is still really bad everywhere. For us, the demographics might vary by location, but the constant is stigma. Regardless of the demographic, folks are afraid of having their status be learned, and all sorts of other things, which just really in 2021 are almost worse than the issues of the 80s and 90s. You know, once folks started living again with the advent of the medications, folks started going back to work, raising families, doing all sorts of things, actually living their lives. And so during that time, several things happened. Support groups and buddy programs slowly disappeared. We focused strictly on medical care, you know, managing our lives medically, and that was it. And so by the time we realized that folks need that support, we kind of had to recreate the wheel. And so it's been challenging and interesting to try and create those places, those psychosocial support for people living with HIV who didn't know that they need it. And there's definitely a need for support. And I'm sorry if this offends anyone, but HIV is chronic and manageable medically, period. The additional things that we go through, like Tez mentioned, we're not just long-term survivors, we're long-term survivors who've been living with HIV for 30, 40 years and dealing with the effects of aging and getting older. So that kind of puts us in a different category. And I really feel like support for folks who don't know how to navigate that system is important. You know, COVID was a kind of a godsend for us because we had to think outside the box and created virtual support groups, which have been like the most amazing gift from COVID, because in one area, there might not have been enough folks that would come out for a hetero men's support group or a young people's support group. And so now the reach is nationwide and folks from all over come in and talk about their same issues. And that was really awesome. In order to enhance the quality of life, we need more things like groups. We need more things like peer navigators, buddies, folks that can reach out to our patients. if we're going to enhance the quality of life for the aging population, we need to learn. We need to learn from what our patients are going through and have gone through. When the person who's been diagnosed for 25 years has always been medically adherent, always had an undetectable viral load, all of a sudden they have a viral load. So I feel like the conventional wisdom is let's focus on why they're not taking, let's focus on getting them to take their meds, not so much maybe why after 25 years does this person have a viral load. You know, I've come to learn that as we age, some of us, people living with HIV have lost partners, have lost friends, are caregiving for older parents, friends, or family members or partners, and often put their own care on the back burner. If somebody is not reaching out to help these folks understand that there's someone that they can turn to, that they don't have to do this all alone, and don't have to be socially isolated, which is typically the result of what we see from the scenarios that I just mentioned. The psychosocial support can be the difference between working through challenges, gaining confidence, and leading a fuller, happier life, and remaining in social isolation or going further into social isolation. The focus on mental health challenges, you know, I was really surprised that the numbers were so low. And I was also surprised that the numbers were so low for PTSD. But I think maybe folks I didn't realize it until Tez started talking about PTSD. Like, oh my God, yeah, at that point, it was like 25 years, I've been burying people and I've been dying and dealing with medications and I've never had a normal life. You know, of course I have PTSD. And I think if we don't talk about this more and more openly in the general community and to folks living with HIV, that we're really, really missing the mark. So in my last 10 seconds, I'm going to say thank you again, Health HIV, and all the presenters here, Tez and Michelle. Great to see you guys. And I am going to turn it over to the one and only Michelle Lopez.
Well, thank you, each and every person. And, you know, again, thank you to Health HIV for actually keeping the focus, you know, the eyes on the prize. I really am going to spend the next 5 minutes, because I'm going to leave my seconds, you know, just at least, you know, to acknowledge. I want to focus in reference to talking about the Black, Indigenous, and people of color. And also, too, I'm going to add the flavor as an immigrant, because the United States became home for me at the age of 16. I'm now 54. And when I got diagnosed, I was 24. And it was not just my diagnosis. So I'm going to also to highlight some disparities and the health iniquities within our communities, because I am a woman that raised a perinatally infected child, and she's 31. So we are both in our 31st year of diagnosed HIV positive. And I will continue to address the health iniquities, because what I have seen is happening here to the aging population. And I want to thank the two clinicians for your closing off overviews when you talked about when we look at this aging population, and patient-centered care has yet to be demonstrated. When we have organizations, we have medical institution that says we provide patient-centered care. And for those of us who are aging with HIV, we are still appealing for that need, because I am someone also too that has multiple comorbidities. You know, I am someone also too that is successfully being treated for my mental health. And it was not until I really have to say I demanded the level of care, because we do have quality of care that is being, you know, provided. But when we look at the indicators on the quality of care, we need to have another indicator. And I'm just saying another. There are multiple indicators that is needed to impact the quality of care for those of us who are aging. And primarily, I would say until each and every state, the care and treatment guidelines recognizes someone living with HIV who hits the age of 50 must and should be referred for a gerontology panel, blood work, and also to assessment. Because fortunately, because of my advocacy, at the age of 52, I had my first appointment with my gerontologist. And that was, again, because of me demanding and letting my provider know this is my life, this is my health. And at 52, because of the symptoms that I was presenting, I needed to have a gerontologist give me that essence of things that was missing. Two things was happening at the same time. When I demanded this from my ID doctor to get this referral, I kept having these viral load blips. I am someone also too who is diagnosed with diabetes. And I have to say my diabetes was not under control. So I am talking about a person who A1C was at a 13 at one point in time. And I said to my ID doctor, because she was, focusing on the blips going on with my viral load. And she was under the impression that, Michelle, you are not taking your medications as directed. And you know what, Tez, I gotta say, I kicked ass because I said, we don't have a resistant profile. Why would you switch my meds? There is something else that's going on. And what came to me when I met with this gerontologist, because of the impact of my A1C, it was correlating and affecting my viral load, okay? Medications didn't have to be changed. Michelle had to put the work in as someone to get that A1C down. Ladies and gentlemen, I am saying my A1C is down to a 7 today. I am no longer having these blips in my viral load. I was kept on my medication that I have successfully been using for the last 7 years. And there's still the advocacy piece that I continually have to do. So I use these clinical, diagnosis that I have to look at the lack of this patient-centered care. So for me, my appeal throughout the states that is providing care for those of us aging with HIV, we need to look at new indicators. It must be put in there. I can't say our new AIDS czar. I am speaking to him on a continual basis because this level of advocacy, it needs to be carried out and stop just documenting. HIV, health HIV has given us some great findings, and it needs to be acted on. And for those of us who gave here today, please do not just have us here, as, we had people living with the virus who's aging talking. There are some key things that came out, and it must be acted on. Thank you very much for listening.
Wow, really, these are some really thoughtful comments and powerful stories of living forward across everyone and from providers alike, And it struck me how each of your experiences, that it looks very different from the experiences of other long-term survivors and those graying with HIV, but in many cases, it looks so eerily similar. And, that we all need more integrated care coordination and deeper social connections with our community and enhanced medical and supportive services. And that many of us in this aging with HIV category, we're not only contending with the effects of aging and chronic inflammation issues, as everybody's pointed out, but that acts as a force multiplier effect on all of our physical and mental and quality of life together. So we all appreciate your work to this cause. I would like to ask a couple of questions to each of you. And if it's all right, I will start off with Tez. Tez, for years, you've spoken about the successes our system has had in expanding access and the uptake of care and prevention services. But you also point out just about every chance you can that our mental health system, our quality of life needs are limited in scope and funding, and especially for older persons aging with HIV. And from your unique grassroots efforts in founding Let's Kick Ass Survivor Syndrome, and through your own personal life's journey that began back in 1983, you've stated that we never saw the obvious and the inevitable future at the beginning of this fight. The idea that one day all of us could get to a place where we could all live forward and age up. And we're there now, but through that lens, Tez, and for those who feel somewhat forgotten about or invisible as we age with HIV, what are your recommendations to improve not just the care and the treatment services, but a lot of this unmet quality of life concerns? How do you prioritize some of the system?
Well, like Valerie said, I was surprised to see that only 25% of people were talking about PTSD. And I think 7% of them talked about ageism. And I wondered how the question was framed, because I think I live through ageism every day of the week. People look right through me as an older adult. I've had clinicians do that to their chagrin. But I think that one of the things that we have to think about is the trauma that we've all experienced. Valerie spoke about it. Listen, it's complicated aging with HIV. It's not easy. It ain't for sissies, and I'm a sissy. It's hard to wake up in the morning and have pain in your feet so bad that you don't want to get out of bed, or to just have legs feel like they're lead for no reason other than you got a poor night's sleep or God only knows what. You don't know what it is. Every day is an adventure, but it's also a challenge. And I think until people recognize that, we must be met with the most greatest degree of empathy possible, which is what I try to put out, is empathy. I want empathy back, understanding our situation as older adults with HIV and as long-term survivors, which are a unique cohort.
Right. The distinctiveness of that cohort can really not be understated. And you're absolutely right. As a person living with HIV and AIDS myself for nearly 30 years, I experienced that same understanding and that same perspective. So I just want to thank you for your work. Val, your story is an exceptional one as well. You began your unexpected journey with HIV really unexpected back in 1985 and a time and place that really doesn't resemble today's system of care and treatment, but yet in many respects, just like as everybody keeps saying, the stigma is still there. And that sense of fear and isolation and pain is still very real, especially as we age. And even the language that we collectively use doesn't always help, right? Even the phrase people living with or aging with HIV has hidden context to some degree. We're more than the sum total of what our viral loads are. And sometimes, I'm just Scott, sometimes you're just Val, Tez, and Michelle, So semantics, good and bad, even today it factors into that discussion. So maybe tell me through your lens, your peer-driven lens, how can we adopt some better language to normalize healthcare navigation for people in our community?
Sorry, you think I would get the hang of this unmuting thing by now. Not necessarily. Scott, when you put it that way, when I think back to the early days when I was diagnosed and I was told to plan my funeral and, this means you can't have kids, right? You know that. I was just like, you told me I'm dying. Like, what? Right. This is what's important? And over the years, when I look at all the progress we've made, it just sometimes it boggles my mind from that to 48 pills a day to we've cured hepatitis C and monthly injections for ARVs and everything in between. Sometimes it just like boggles my mind. Again, the one thing that hasn't changed though is stigma. And I think we've learned along the way lots of different forms of stigma and reasons that it happens. And so, yes, stigmatizing language is really something that has become important to me and to a lot of people living with HIV. And we don't just use horrible language in HIV. We use it in behavioral health. We use it with substance use disorders. We use horrible language that further stigmatizes everything where folks already feel stigmatized. You know, and it's today even, I hear people say, even providers, full-blown AIDS. Like, honestly, when was the half-blown AIDS? Because I missed it. Was there a quarter-blown AIDS? Darn. You know, and so I joke about it, but, you know, a lot of the things that we say are just like fear-mongering terms and words that don't do us any good. And whether we realize it or not, the internal stigma that a lot of folks feel, I did for a really long time, is because of stigmatizing language. You know, when you think about the word infected, so for average people, maybe not medical providers, but when they hear the word infected, they're like, ew, right. And so I got to a point where I couldn't use that term to refer to myself or anyone that I care about. And I realized that it was just putting like little dings in my soul all the time. And so now that you're infected and he's infected and your case manager because you're infected, it just wears on you. And I didn't even realize it over all of those years. You know, and there's so many stigmatizing terms that we use where we take the power away from the patient, the person living with HIV. We call them compliant or non-compliant. That tells me that I'm following your order or I'm not following your order. I'm adherent. That gives me buy-in to my medical care. It's more praiseworthy. It certainly makes me feel better about what I'm doing. And I could go on all night about language. I will if you let me.
You have the floor if you'd like.
And, you know, so I'll just take like another minute and
Perfect.
I hear people still today, people living with HIV will say, I'm HIV. Since I'm HIV, I'll even hear, I know. And I'm like, I'm not HIV. I'm an awesome woman living with HIV. Like this thing cohabitates in my body, but that's not me. You know, and I'll even hear folks in the field, case management or providers say things like that. And we don't realize how we process that and turn it into internal stigma. So I really, really think that in order to reduce stigma, I mean, I'd like to totally eradicate it, but I don't believe that would happen. But I really do think we need to be conscious of the things we say and the way we say them. Thank you.
Absolutely. I carry around my A3 designation as well. I remember writing a poem when I was first diagnosed, 99 T cells and 99,000 viral loads, couldn't put Humpty Dumpty back together again. But the casual indifference back in the day still carries on to me in this internalized stigma as I live with it in that respect. So I really understand those remarks, and I'm sure many of us still have that. Let me ask, Michelle, your journey in living with HIV really began back in 1981, but it culminated in an actual journey while you were on a train with you and your daughter, the night that you left your abusive partner. And in watching billboards pass you both by, you saw a number to call to reach out for help. And that's when faith and hope collided and met your life's really challenging circumstances. And while awareness of services and testing and treatment, it really does get people into services earlier now more than ever. It seems as though those issues are still the three main drivers that kind of constrain our system today, the care continuum effect that we're all kind of talking about in that respect, if you will, where issues are put to an adherence or a viral load suppression test, and knowing that not everyone comes to services through a combined universal system. Some people start their journey on a train like you, or getting into Ryan White Care or ADAP programs, and others began their care with state Medicaid or Medicare, others on employer-sponsored systems, and some not at all, or some too late. So if you will, Michelle, if you had a magic wand, how would you call out all the disparities long embedded in our system that haven't necessarily kept up with meeting the needs of those aging with HIV? You know, what would be your recommendations or your priorities if you had that magic wand? Where would you start?
We have to continue. My magic wand will be able, wave that wand, to continually have the description and the representation of individuals who are living with this virus. We must be able to act on having us at decision-making tables, because gone is the whole concept of meaningful involvement of people living with HIV and AIDS, right? And I'm saying it, and I'm just gonna piggyback a bit on the question you asked, Val. Okay, we are not HIV people. We are people living or diagnosed with HIV. And I'm gonna keep saying that. The WELL Project is an excellent project we have that has created a full information and educational guide, and it's available for providers and consumers. So I'm also too gonna just reference that. The decision making that continues to go on and to make the impact in our lives. If we are not there as a Black woman, as a woman of color, if we are not there as an immigrant, if we are not there as a gay or LGBT transgender identified person, if we are not there as a person again who is real, that is disproportionately continually affecting our community. If we are not there at these decision-making tables, these are the things that continues to drive the health inequities, the disparities, and all of the different areas that we need to fix in HIV care, prevention, and treatment.
I appreciate those comments. I think we all do. I mean, just, you're right. Semantics matters in so many contexts, and having us at the table to make not just the titular Public Service Act resource allocation committees through the Ryan White service programs, but to really make impactful conversations. So I appreciate that. Maybe we've got a really good question that kind of follows up a little bit on this from the audience that says, and this is to all of you, so I work as a medical case manager for Ryan White clients, and what do you all panel members suggest to address health literacy to the younger under 40 person? How would you suggest health literacy?
Well, first of all, I think Ryan White has a long way to go in taking care of older adults with HIV. I mean, I think that's been one of the gaps in the Ryan White Care program. But I think you're talking to three of your best resources for that, which is older adults with HIV who can teach younger ones about these things. Because, I don't want to call us mentors, because I learn as much from young people as I do they learn from me, I hope. But I do think we're standing as sentinel for people who have survived and are living and some days thriving with HIV. So we can be helpful in that regard in helping pass our knowledge on to the next generation. And also, we need them. I need somebody to push my wheelchair. It's a hard fact.
For me, I really have to say the literacy piece, and again, the mentoring and the life shared experiences is very, very important for us to get this to the young folks. Because, those, again, who tend to forget the past, will carry out the same, issues that we failed on, that we did not address. For those of us who are here, I think it's a real, what I would say, meaningful reason why some of us, are being called upon to advise in some of these advisory boards. And I'm really, really concerned. Why have we allowed meaningful involvement of those of us living with HIV that completes this dysphoria. Why aren't we at these tables? Why aren't we advocating in that aspect of it? There are things, again, that, because of these surveys that are being carried out, now it's not just to collect information, now it's to act on what you have heard and develop collaborative efforts. No man is an island. Where we have gotten today was not done by one or two individuals. No, it was done by a quadrille of individuals, right? Race, color, class, creed. Those were the things in there. Yes, it was acknowledged. Who is at the table? Today, now, it continues to me who you know to get you at that table. I'm sorry, my life is worth more than that. So.
And I feel like sorry, Michelle.
No, go right ahead, hon.
I feel like health literacy is something that is taught and learned over a period of time. And at what point in this young person's life or any person's life are we talking about teaching health literacy? Because in early diagnosis or in a time of crisis, a lot of folks just can't hear anything that's being said to them. And so if we go down a tick list of, well, you need to know this and you need to do this and you need to know this and you need to, it doesn't stick. And so I feel like it's a thing that I learned over time with my experiences that I could combine with the textbook information, but it's not an easy thing. And, young folks face a completely different set of issues than we face. So I think repeat it, be patient with them. And most importantly, be aware of where are they in their journey? Can they even hear this? And Michelle, as far as being at the tables, that's one of the things we lost too when we went back to work, where the buddy programs and the support groups and everything went away. I find that a lot of Ryan White consortium meetings take place during the day at times when people who work can't get there. Sometimes in places where people who don't work can't afford to drive there. There are a lot of barriers. And if they really want us at the table, they need to change their ask.
Yes. We're going to be outspoken and we're going to keep bugging your asses about this stuff. But all of us, not just those of us on this call, but those who reject ageism, we reject stigma, and we demand that you see us for who we are in our fullness, in our blackness, in our femaleness, in our maleness, and whatever it is, that you see us as full beings who need and deserve the care that we're not getting. We're not getting it mental health care wise.
Yes, and if I may, we don't have to wait until we are 50 and 60 and 70.
No.
Okay?
No.
We know we're going to age. Let us get back at these decision-making tables. We can get it again. We did it before. We can do it again.
I think you're right. I think those are the perfect final words. I mean, we can do it again and see us. And in seeing all of you, I just do want to thank you. I want to thank John. I want to thank Donna, Tez, Michelle, Val, everyone in the audience for listening in and participating in this roundtable, and know that this is an urgent matter. And you're right, the data is great to collect, but action needs to happen now. So see us now, hear us now, and thank you so much. And I think that is all for now. So please have a great session.
Yes.
Awesome.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.